So good evening, everyone. Hope you all are doing well. In today's session, we'll do the DVLA and diabetes, the 2023 update. This is my lecture number 67 in my lecture series. I have put this full video as preview, so hope you all will benefit from it. In this particular session, I will be also covering the recalls of the SCE 2023 exam as regards DVLA scenarios. So it will be a good revision and very important and high yield for the coming exams. Of course, all my videos are very helpful for specialty exams, European board exams, MRCP, and other endocrinology board exams as well, and definitely in clinical practice. So as I mentioned that I'll be covering all the latest updates for the DVLA. We'll be covering the different information guides which are available on the DVLA website, one by one in different case-based scenarios. So we'll be looking at the INF 294, 188/2, 188/5, and INS 186. This was the latest update in 2023 in terms of the INS 186. As regards my previous video in my lecture series, all of the updates are already the same, like the 1882, 1885, and 294 are the same. Only the newest update was the INS 186, which I mentioned is in 2023. So let's look at the case scenario 1. This was asked in the recent SCE 2023 exam. Type 1 diabetic patient, of course, insulin-treated diabetes. He can definitely drive, but need to inform the DVLA. But the question which was asked was advice as regards the blood sugar testing. Correct answer: should check your glucose less than 2 hours before the start of the first journey and every 2 hours after driving has started, independent if the patient is wearing a CGM or not. So this is extremely important. And we look at the paragraph quoting these guidelines. So this is from the INF 294, as I mentioned. Drivers with insulin-treated diabetes as our patient are advised to take the following precautions. You should always carry your glucose meter and blood glucose strips with you. Even if it's very important, this statement, even if you're using a real-time CGM or a flash glucose monitoring system. You're aware of the real-time as well as a flash glucose monitoring. Real-time will be the Dexcom and the flash glucose monitoring system will be the Libre. You should check your glucose less than 2 hours before the start of the first journey and then every 2 hours after the driving has started, which was the answer in the question scenario 1. A maximum of 2 hours should pass between pre-driving glucose check and the first glucose check after driving has started. More frequent testing may be required if for any reason there is a greater risk of hypo, for example, after physical activity and on altered meal routine. In each case, if your blood glucose is 5 millimole per liter or less, eat a snack. If it is less than 4 millimole per liter or you feel hypoglycemic, please do not drive. This is case number 2. This was also a SCE recall scenario of the recent 2023 exam. An insulin-dependent diabetic patient took short-acting insulin in the morning without eating breakfast and then checked his sugar, his or her sugar before setting out to drive. And the blood sugars were found to be 4.8 millimole per liter. So what's the next best step? Correct answer will be eat a snack and drive only when the blood sugar is more than 5 millimole per liter. So again, advice, as I mentioned in the first slide, in each case, your blood glucose, if it is 5 millimole or less, eat a snack. If it is less than 4 millimole or you feel hypoglycemic, do not drive. If hypoglycemia develops while driving, stop the vehicle safely as soon as possible. You should switch off the engine, remove the keys from the ignition and move from the driver's seat. You should not start driving until 45 minutes after a finger prick blood glucose has returned to normal, which should be at least 5 millimole per liter, because it may take up to 45 minutes for the brain to recover fully. So this is a very important statement asked several times in the previous exam. If you're using a real-time CGM or a flash glucose monitoring system to check your blood glucose and the reading is 4 millimole per liter or below, you must stop driving and confirm by using a finger prick glucose testing. So again, the importance of making sure that you carry the finger prick glucose testing with you, even though you may be on a CGM, real-time or flash CGM. And your finger blood glucose level must be at least 5 millimole before you return back to driving. Remember, 45 minutes it may take up to for the brain to recover fully. So a bit about hypoglycemia as quoted in the guidelines. Hypoglycemia, also known as hypo, is a medical term for low blood sugar. What is a severe hypoglycemia? It means that assistance of another person was required. So we'll be quoting this terminology in the subsequent slides. The risk of hypoglycemia is a main danger to safe driving. And of course, this may endanger your life as well as of the people on the road if you ignore the warning symptoms. Early symptoms of hypoglycemia may be feeling trembling, hungry, fast pulse, palpitations, anxiety, or tingling limbs. So these are very important to be identified. Sleep hypoglycemic episodes is another terminology which you should know for the guidelines. If you have frequent sleep hypoglycemic episodes, you should discuss them with your doctor, even though this is unlikely to affect your application if it was a Group 1 driving license. The Group 2 has a total different rule for sleep, and I will talk to you about it in the next slides. So severe hypoglycemia means assistance of another person is required. Sleep hypoglycemic episodes equally important, especially for group. Now, as I mentioned that all these lectures are part of my lecture series. Of course, this lecture is a free lecture for the DVLA, but I have 67 in all lectures now. So if you'd like to subscribe to the full lecture series, you can WhatsApp me on this number or email me on the mazirules@gmail.com. A bit about my latest lectures, the ones which I've released this month are the latest guidelines of PCOS, which is by the European Society of Guidelines, Society of Endocrinology Guidelines, and the 2023 Bethesda guidelines for thyroid cytopathology reporting. So both of them were released by me this month. Apart from that, I have a whole list of lectures surrounding diabetes. If you can have a look at all the lectures, and it's very popular over the last 2 years since I've recorded these lectures, and these are all part of my paid lecture subscription. There are several topics which are high yields for thyroid, adrenal. There are some quick revision concepts for the exams. There is recalls of the previous exam, important pearls from Oxford Handbook 4th edition, and exam lab question and answers with explanations. Whole spectrum of thyroid, which is especially relevant in terms of exams. Guidelines as well. There is section on adrenal as well, which covers all the important topics which have been part of exams as well as clinical practice. There are good sessions on lab endocrinology, inherited endocrine syndromes, whole spectrum of pituitary, which is important from exam perspective as well as from the clinical practice. Reproductive endocrinology wise, good number of sessions, calcium metabolism, lipid disorders, pediatric endocrinology, all the spectrum of endocrinology is being covered in this lecture subscription, which is now in all 67 lectures. The 67 lecture is the current one which you are listening. And I have more lectures coming up. I'll be covering more guidelines. The latest one which I'll be covering will be the NICE 22 obesity guidelines, and I'll put a comparison with the ADA 2023 obesity guidelines. I'll cover the endocrine disorders in pregnancy. I'll be covering a topic on diabetic foot and Charcot neuropathy. Turner syndrome, very favorite for the exams. I'll cover the Cincinnati practice guidelines, which is very important. I'll do a case-based approach to diabetic neuropathy and MEN2 syndrome. I will be completing the recall of 2022 and 2023 exams. Currently, half the questions are available on the paid subscription. I'll be doing a session on endocrine emergencies, and there will be many, many more lectures and newest guidelines. And the good part of the subscription is that, as I mentioned, it is not only about these lectures. You'll get lifetime access to all my upcoming lectures lifelong. So it's a one-time subscription fee for lifelong subscription for all the lectures. Case scenario 3, Group 2 vehicle driver, insulin-dependent diabetic on real-time CGM, wishes to just follow the CGM and stop finger prick testing for blood glucose. What's your advice? Correct answer is Group 2 vehicle drivers must continue to use finger prick testing for the purpose of driving. RT, CGM, and flash glucose monitoring system are not legally permitted for the purposes of Group 2 driving. So whether they have CGM or not, they must use finger prick testing for the purpose of driving. But what about Group 1 drivers may now use finger prick testing and CGM for the purpose of driving. Group 2 drivers must continue to use finger prick testing for the purpose of driving. Why? Because RT, CGM, and flash glucose monitoring are not legally permitted for the purposes of Group 2 driving. This is extremely important from exam perspective. All glucose monitoring systems used for the purpose must carry the CE mark, as there are times when flash glucose monitoring and real-time CGM users are required to check their finger prick glucose Users of the system must always have finger prick glucose monitor available and test strips available when driving. This is from the INF 294 guide. Important note for car or motorcycle, which is obviously group 1, about using RT-CGM and flash glucose monitoring while driving. You must get a confirmatory finger prick glucose in the following circumstances: if your blood glucose is 4 millimole or below, because you know that there is a lag in the flash glucose monitoring and the real-time CGM in terms of the hypoglycemia. For example, if we correct the hypoglycemia, then it will take times for the numbers to change in the flash glucose monitoring, whereas the finger prick glucose monitoring will be the most reliable to see the trend in this scenario. So if your blood glucose is less than 4 millimole per liter or below, get a confirmatory finger prick glucose. If you have symptoms of hypo, if your blood glucose monitoring system gives a reading that is not consistent with your symptoms, that is, if you have symptoms of hypo and your system reading does not indicate this because there is a lag, remember, in the CGMs. If you're aware that you are having hypoglycemia or having indication of impending hypoglycemia at any other times recommended by the manufacturer and your of your glucose monitoring system. Now, alarms on RT-CGM, which is real-time CGM, must not be used as a substitute for symptomatic awareness of hypoglycemia. This is very important. You must recognize hypoglycemia through symptoms you experience for the purpose of group 1 driving. Should you become reliant on these alarms to advise you that you are hypoglycemic, you must stop driving and notify the DVLA. Very important. If you're using glucose monitoring system, you must not actively use it while driving your vehicle. You must pull over in a safe location before checking the device. You must always stay in full control of your vehicle at all times. The police can stop you if they think you're not in control because you're distracted and you can be prosecuted. Case scenario 4. Again, this was a part of SCE Recall 2023. Group 2 vehicle driver, insulin-dependent diabetic, has one episode of severe hypoglycemia. We already looked at what is severe hypoglycemia in the previous slide. It needed assistance from the wife. What should he do next? Correct answer is must stop driving and tell the DVLA. Because even if he has a single episode of hypoglycemia which required assistance of another person, which is severe, even if this has happened during sleep, so even sleep hypoglycemic episodes become relevant for group 2 drivers, and they must stop driving and tell the DVLA. This is not much in scenario of group 1. So this is something to be remembered. Any degree of impaired awareness of hypoglycemia should also make them stop the driving and inform the DVLA in terms of group 2 drivers. So here is more in detail about the same. So group 1 drivers, car and motorcycle, you need to tell DVLA if any of the following happened to you. You need to tell the DVLA if you have more than one episode of severe hypoglycemia while awake within the last 12 months. So this is needing assistance of another person, as I mentioned for the severe. You develop impaired awareness of hypoglycemia. That is difficulty in recognizing the warning symptoms of progression. So this is for group 1 drivers. Group 2 drivers, which is bus and lorry, you must stop. Okay, this is important. Driving group 2 vehicles and tell the DVLA if you have even a single episode of severe hypoglycemia, even if this has happened during sleep. You have any degree of impaired awareness of hypoglycemia. So this is different from developing an impaired awareness to have any degree of impaired awareness. So this is more stronger. I mean, any degree of impaired awareness should make you stop driving for group 2 vehicles and tell the DVLA. All drivers, group 1 or group 2, must tell the DVLA if they suffer severe hypoglycemia while driving. You or your medical team feel you are at high risk of developing hypoglycemia should notify the DVLA. An existing medical condition gets worse or you develop any other condition that may affect your ability to drive safely. In regards to eyesight, also there are guidelines that all drivers are required by law to read in good daylight with glasses or corrective lenses if necessary. A car number plate made after 1st September 2001 from a distance of 20 meters. Also, the visual acuity with the aid of glasses or contact lenses if worn must be at least 6/12 on Snellen scale, decimal 0.5, with both eyes open, or in the working eye if monocular. If in doubt, speak to your optician. As regards limb problems or amputations are unlikely to prevent driving. They may be overcome by driving certain types of vehicle, for example, automatics or those with hand. Coming to case scenario 5, group 1 vehicle driver found to be uncontrolled type 2 diabetic at time of MI, which sustained 4 months ago. So he had an episode of myocardial infarction 4 months ago. Since that time, he's on a combination of metformin plus SGLT2 inhibitor plus basal insulin. And now this has gone over around 4 months. What should be the best advice as regards informing DVLA? In this is the especially relevant for temporary insulin treatment, whether it is gestational or post-MI. In this scenario, if any disabling hypoglycemia occurs, they should inform the DVLA. Treatment continues for more than 3 months. Like in this scenario, post-MI, it continued for more than 3 months, around 4 months. Or in gestational diabetes, if it has continued for 3 months, even after the delivery of the baby, the insulin treatment, then they should inform the DVLA. However, they may continue to drive, but must notify the DVLA. So this is in regards to temporary insulin treatment, which is for gestational diabetes or post myocardial infarction. So again, this is more emphasizing the same. And this should also include trial participants for oral or inhaled insulin are also examples to be included as receiving temporary insulin. Case scenario 6. This is also a SCE 2023 exam recall. This incorporates the INF 188-2, which is information for drivers with diabetes treated by non-insulin medication, diet, or both. Group 1 vehicle driver, type 2 diabetic on GLP-1 agonist should inform DVLA or not. Correct answer, need not inform the DVLA. So if the patient is managed by other medications, such medications include metformin, DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 agonists as the outpatient, or non-insulin injectable, basically GLP-1 agonists. Now, these are non-hypoglycemic oral medications or non-insulin injectables. So, Group 1 vehicle may drive and need not notify the DVLA, provided the requirements set out in Appendix D are met. This is regarding visual and all these things. May drive, but must not notify the DVLA if clinical information indicates the agency may need to undertake medical inquiries. About Group 2 bus and lorry, may drive, but must notify the DVLA. Okay, this is very important. So even if the patient is on managed by medication, which are non-hypoglycemic oral medications, for Group 2 bus and lorry drivers, they may drive but must notify the DVLA. This does not apply for Group 1 car and motorcycle vehicle drivers. Now, talking about diabetes treated by medications other than insulin, in this, I'm talking about specifically those can cause hypoglycemia or those tablets which carry hypoglycemic risk, like sulfonylureas or glinides, which are ipaglinide and nataglinide. Now, again, in Group 1 car and motorcycle may drive and need not notify the DVLA. In Group 2, may drive but must notify the DVLA. Now, they should make sure about the hypoglycemia things even in this regard. So no more than 1 episode of severe hypoglycemia while awake in the last 12 months, and the most recent episode occurred more than 3 months ago. Should practice appropriate glucose monitoring at times relevant to driving and should be under regular review. On the other hand, if it's a Group 2 bus and lorry vehicle driver taking a tablet which induces a hypoglycemia risk, you should not have any episode of severe hypoglycemia in the last 12 months, should have full awareness of hypoglycemia, and definitely should do regular monitoring of blood glucose, as was mentioned in the previous slide. That is no more than 2 hours before start of first journey and every 2 hours while driving. So this is something to be kept in mind in context of diabetes managed by tablets carrying hypoglycemia. Case scenario 7, here we have covered, I have mentioned about the INF 188-5, which is lorry and bus drivers with diabetes treated by diet alone. So Group 2 vehicle driver managed by type 2 diabetic, managed by diet alone. What's the advice regarding notifying DVLA? May drive and need not inform the DVLA. Now, if you look, if the diabetes is managed by diet or lifestyle alone, both Group 1, Group 2 may drive and need not notify the DVLA. So this is very, very important to understand in this guideline. Now, this is the last slides. This includes the lorry and the bus drivers. I mean, there's one more section I'll be doing after this. So basically, as I mentioned about the diet alone, so may drive and need not notify the DVLA. Of course, you need to take into context the visual parameters, which we already discussed in the previous slide. Okay, so by law, you must tell us if you start treatment with tablets, but your patient was on diet alone, for example, in the previous slide. If the patient is taking drugs with hypoglycemia risk like sulfonylurea or glynide, then definitely should be informing the DVLA, as I mentioned, in terms of Group 2 vehicle drivers. Now, this is INS 186. This was latest updated in 2023. This is something new from my previous lecture in my lecture series. So this is a guide for drivers with insulin-treated diabetes who wish to apply for Group 2 entitlement or bus and lorry. So this is INS 186. Qualified conditions you must meet: should not have an hypoglycemic event requiring the help of another person in the last 12 months. So no severe hypoglycemic episode is allowed. You must have full awareness of symptoms of hypoglycemia. So any degree of hypoglycemia unawareness is not accepted. You must be able to show an understanding of risk of hypoglycemia. You should check your sugar at least twice daily, even on non-driving days, and no more than 2 hours before the start of the first journey and every 2 hours after driving has started. This must be done using blood glucose meter with a memory function to measure and record blood glucose. FGM and real-time interstitial blood glucose monitoring systems are not permitted for the purpose of Group 2 driving and licensing, as I already mentioned. Group 2 drivers who use these devices must continue to monitor capillary blood glucose level via finger prick testing. Very important for the exam. You must always keep a fast-acting carbohydrate within easy reach when driving. You must attend an examination every 12 months with an independent consultant specializing in treatment of diabetes. You must at least show 6 continuous weeks of readings available on the memory of your blood glucose meter for the consultant or GP. This is a change from the previous update. So back one year ago, it was mentioning here 3 months, but now as per 2023, it's 6 continuous weeks of reading should be available. You must have no other debarring medical condition. You must sign an agreement stating that you will comply with direction of doctors treating your diabetes and that you will report immediately any significant changes to your condition to DVLA. General advice, more about hypoglycemia. If it's impaired awareness, panel has also defined impaired awareness of hypoglycemia for Group 1 drivers as inability to detect onset of hypoglycemia because of total absence of warning symptoms. Group 2 drivers must have full awareness of hypoglycemia. Severe hypoglycemia, I already discussed and I told you before. What if recurrent severe hypoglycemia guidance? Advice for Group 1 drivers who have had more than one episode of severe hypoglycemia while awake in the last 12 months must not drive and must notify the DVLA if it is recurrent severe hypoglycemia. Advice for Group 2 drivers after every episode of severe hypoglycemia in the last 12 months must not drive and must notify the DVLA following all episodes of severe hypoglycemia. Severe hypoglycemia while driving, all Group and Group 2 drivers who experience an episode of severe hypoglycemia while driving must not drive and must notify the DVLA. Impaired awareness, as I already mentioned. Some other scenarios which is mentioned in the guidelines about pancreas transplant. For Group 1 may drive but must notify DVLA. Post pancreas transplant, Group 2 bus and lorry may drive but must notify the DVLA. If post islet cell transplantation may drive but must notify the DVLA, and Group 2 may drive but must notify the DVLA. So these are some other scenarios as well. What if the seizures are provoked by hypoglycemia? They definitely need a period of driving. Group 1 as well must not drive and must notify the DVLA. Group 2 bus and lorry must stop driving and must notify the DVLA. So seizures, if they are provoked by hypoglycemia, and now require a period of driving due to the prospective risk of a further seizure. And that's the end of my today's session. If you like to subscribe to my full lecture series, get in touch with me, and it will definitely benefit you for your exams and clinical practice. Thank you so much.